chat a little bit about Upstate Venture Connect. We are a non-for-profit 501c3 organization that has been in existence for about 10 years, really helping to connect entrepreneurs across the region and get them the resources that they need to regrow our economy. This is an incredible moment in time for our region where we're faced with a lot of common challenges. And our goal through these webinars is to share with you the perspective of some of the people who are on the front lines of these issues in terms of how they have dealt with the first wave and how they are anticipating the future. With that, I'm going to introduce my colleague, Alex Zapesochny from the Rochester Beacon.
All right, thank you, Nasser. It's a pleasure to be collaborating with UVC as well, and good afternoon to everyone on here with us today. We also want to thank the Central New York Business Journal and the Utica Observer Dispatch for joining in our efforts today. As we all know, and as Nasser just alluded to in the introduction, our healthcare systems have been facing an immense challenge this year. Their work keeping our community safe from COVID-19 and as critical employers in our region will both be aspects of our discussion today. I'm going to start by providing a brief introduction of our superb panel. Our first panelist today is Dr. Mark Taubman, CEO of the University of Rochester Medical Center. The University of Rochester Medical Center is a leading academic medical center formed obviously in Rochester, New York. It forms the centerpiece of the U of R's health research, teaching, and patient care missions, employing over 26,000 people at its hospitals, practices, and research centers. Our second panelist today is Dr. Kim Townsend, CEO of the Loretto system, which is based in Syracuse. Founded in 1926, Loretto is a comprehensive continuing healthcare organization providing a variety of critical services for older adults throughout Central New York. It has over 2,500 employees and provides services to over 10,000 individuals and their families annually. And our final panelist today is Dr. Bill Streck, CEO of the Bassett Healthcare Network, which is headquartered in Cooperstown, New York. Bassett is an integrated health delivery network that includes multiple hospitals, nursing homes, and numerous medical specialists. It delivers care within a 5,600 square mile area in Central New York to a largely rural patient population. Thank you all for agreeing to join us here today on our program, Rebuild Upstate, the Outlook for Healthcare. And the first question, which is addressed to each of you, is as follows. First, we want to deal with the healthcare side of COVID-19 and what you all experienced. And the specific question is, what lessons did your organization learn in dealing with the initial COVID-19 outbreak? And how are those lessons informing your current practices and preparations for a potential future spike in COVID-19 cases in our region? And let's start off with Dr. Taubman, please.
Thank you. I think that one of the things that we learned most was our ability to actually open up the system, open up beds and close elective procedures, elective visits quickly. I think in doing so, were we to have a similar type of episode, I think we would be able to respond in a less dramatic way. I think that in fact, we almost opened up 400 beds because we didn't know how long it would take and waiting for a surge, which didn't happen. We're now quite comfortable, and I think the state is, that we could have a much more measured response. We also have the PPE available, because I think one of the concerns was that we had to save PPE and therefore close the system quickly. We also took advantage of this to really ramp up our telemedicine. We were able to go from 20 cases a day to 6,000. And that's something that's not going to back down, but it's something that we'll be able to incorporate into the system. So I think we'll be far better prepared to take a more measured response and one that potentially has less economic impact yet take care of the patients well.
Very good. And Dr. Townsend, would you mind going next?
Well, you know, I would say brilliant minds think alike. So I would echo what Dr. Taubman has just said. I think what's really been great lessons for us is that we have accelerated our path to digitalization through the use of telehealth, remote patient monitoring, as well as data aggregation tools for contact tracing and hotspotting. And then I think, as Dr. Taubman said, just that rapid action right at the beginning, which for us began on February 29th, closing our facilities to visitors, going out into the market and buying PPE very aggressively because, of course, we know the supply chain had collapsed by the first week of March. And then just careful management, communication with all of our stakeholders, but most importantly, our employees, so that they felt safe and comfortable coming to work. Those were all things that I think led to our success and really confirmed for us some things that we knew were important to do.
Excellent. And Dr. Streck?
Well, we certainly shared all these characteristics of shortages of equipment, anxiety, introduction of telemedicine. I would say the one thing that might be different about the Bassett experience is that we are a more rural location. We have clinics and hospitals over 5,600 square miles here in central New York. And what we found and what we did is disperse a hotline triage, two-level triage, testing capability within a week for that whole region. And so we're able to handle the early, I would say, high anxiety phase of COVID for the Upstate experience, where we didn't know what would happen and people needed information. And so we effectively created triage, screening, treatment that worked quite well with thousands and thousands of visits, 800 calls a day on the triage line, hundreds to nurse triage, physician triage, and then, if necessary, treatment. So it was that dispersion of a population-based enterprise that was a success. And it was actually, as it turned out, the main component of our endeavor. Like Mark, we freed up beds and everything, but like most of us in Upstate, we did not experience the tsunami of sick inpatients that created such high anxiety in the beginning.
I mean, one of the things that I think we hear quite a bit of recently, and this is kind of staying on the medical side at this point, is that a lot has been learned about the actual care of patients who contract COVID-19, and that has helped for the lethality of it to not be kind of as high as it was at the beginning. And maybe kind of starting again with Dr. Taubman, could you speak about what it is that your organization has learned that would also contribute, just from a standpoint, not so much from PPE or capacity, but just the actual care that seems to have improved in recent months?
Sure. I think that part of it is we have learned in a better way how to manage people who are deficient in oxygen content. Probably less aggressive at putting them on ventilators and more aggressive using other approaches first. And I think that that's something that we've seen around the country, that as you get more and more comfortable with this disease, you're also more comfortable with waiting longer to ventilate people. We've obviously now learned that dexamethasone is very effective in reducing morbidity and mortality in patients who have pulmonary problems. Remdesivir, not as effective as dexamethasone, but certainly effective. But I think, you know, like any disease, it's partly just the familiarity with patients. You get to learn when do they look like they're getting in trouble? When do they look like they're not getting in trouble? When can we, and so I think that as time has rolled on, we're just far more comfortable seeing in which patients need to be hospitalized. I think in the beginning, you tend to err on the side of hospitalizing everybody, and then you realize there are a lot of patients who don't need and probably to be hospitalized, probably do better. So I think we're still learning. We're still trying to understand the role of convalescent serum, but I think it's just being familiar with the patients and also not having a volume that overwhelms the system. I think it's very different when you can have all of your patients taken care of in units by critical care experts and critical care nurses, as opposed to when you get totally overwhelmed, where you don't have that same expertise for every patient.
And Dr. Townsend, as you address the same question, it's of course notable that a large portion, or really kind of most of the population that your organization deals with are older patients, medically, kind of by definition, more medically at-risk populations. What are some of the things that you've learned and some of the things that you want to make sure are implemented in the future? Just, I mean, partially on the medical care side, but also just in terms of how should they be living their lives, since nobody wants to kind of for the foreseeable future not be able to be around friends, not to be able to be around loved ones. It seems to be a particular challenge with kind of the nursing home and similar environments.
Well, I think what has been really critical for us is the availability of testing in a post-acute environment. And so the availability of both employee testing as well as resident testing of the 10,000 people that we care for each year across our system. And then once we understand, the testing piece of it, I think what was amazing to us was just the large number of asymptomatic positive employees who were the relatively large percentage who really had no idea that they were ill. And so once we determined that, of course, we were able to put people out of work on quarantine. But in addition to that, as cases came up, we were able to cohort those COVID positive cases in a dedicated COVID unit. Now, the unfortunate thing is in New York State now, hospitals are no longer able to discharge COVID positive patients to post-acute care settings, but we are more than able to care for COVID positive patients and did so very successfully when hospitals were still allowed to discharge them to our locations. So I think if I'm an older person in the community or someone who's immune compromised, we go back to those core 4 practices, which are wearing a mask, good hand hygiene, social distancing, and avoiding large groups. And we know that that's something we're going to be focused on as we're given the opportunity to reopen our facilities. And those, we believe, will help us keep our residents safe.
And Dr. Streck, same question around kind of what we've learned from a medical side, and also is there some difference in the fact that your patient population largely is rural, is not necessarily kind of living in a high density environment? Is there anything from that standpoint that as you think about how your system and how the communities that you serve need to, what they need to do next, that patient population should be, that there's something to be learned in terms of how to provide advice to them?
One thing that we share with Mark and Kim and everyone else is that we've all learned that we are now coping with COVID, not the COVID crisis, but its presence and the fact that it influences all our behaviors, so that you can't enter a clinic now in our system without having your temperature taken. We have screening, you have protocols. And so there are 2 aspects of what we've learned here. First, we have to continue to be cognizant of COVID, and so have protocols to address patients and who might have it, and so protect both other patients and staff. So safety, as everyone knows, has become a major preoccupation for patients and for staff. So a lesson learned is that we have to redesign our systems to accommodate these different tracks and make sure that we are protective of staff and patients, even as we are capable of addressing those who might be COVID positive. To me, that is the lesson that we are applying moving forward now. And as we have a return of business, and we've seen this fairly favorable return back to more conventional volumes, that just puts more pressure on the system in terms of testing before surgeries, in terms of patients coming into clinic. So there's a logistical lesson here that is not going to end anytime soon. And then I will just add a topic I'm sure that will emerge later in the discussion. There's another whole world we're trying to deal with in terms of colleges, the students coming back, what the colleges expect in terms of testing, still the shortage of testing capabilities, what do businesses feel they need. So we are grappling with, I would say, the post-COVID questions as a system. And there are just a lot of organizations, businesses, and individuals who are seeking answers to questions that are legitimate and for which we have yet to find the ultimate solutions.
So shifting gears a bit, as I mentioned at the beginning, the medical and healthcare services sectors are, of course, also critical to our region because they employ so many people and because they have a substantial impact on the local economy. From each of your perspectives, what problems has COVID-19 exposed or highlighted about the business models of healthcare organizations and their financial sustainability? And I think we'll begin this one with Dr. Townsend.
Thank you. Well, just to kind of frame the conversation, in the long-term care or post-acute care sector, COVID-19's been described as an extinction event. So of the 100,000 individuals in New York State who are in nursing homes, 63% of those individuals are Medicaid beneficiaries. And we know that the Medicaid rate for long-term care in New York State is on the average $70 per person per day below cost. So that is not a financially viable business model for those of us in the safety net with 60% or more of the individuals we serve being Medicaid eligible. So for us, COVID was financially devastating. Just the need to go out into the marketplace and purchase PPE in informal markets where an 88-cent N95 mask in January is $6.99 in March, and the lack of available testing kits, setting up a COVID unit, the mandated employee testing, which we've done, about $1.5 million worth of tests with no state or federal funding. Perhaps FEMA may reimburse. The plummeting census, we're a lagger behind hospital census and the cancellation of elective surgeries. So just framing this from an economic perspective, the impact of COVID will be felt for many years to come.
And Dr. Streck, if you could address the financial sustainability question next.
Well, there are two elements to the financial impacts. One is on the health system, and certainly our curve of volumes followed, I'm sure, Mark's curve, and probably was a little ahead of Kim's because hers was the subsequent part. But we had 30 and 40% decrements in admissions and clinic visits. So it was a very substantial, multi-million-dollar reduction in revenue, offset minimally by modification of employee roles to try to phase down. We did not furlough, but we reduced hours for some in selective areas. The sum of all that, we really don't know just on a health system basis because of the tranche money from the Provider Relief Act. So we got some money. Will it be enough as this plays out? We don't know. But we know that the numbers will not net favorably, I'll put it that way. So that's for us to cope with. And then economically within the region, particularly for Cooperstown, a tourist village, that's really been quite devastating economically. All the museums closed, baseball camps closed. So our whole region has been economically depressed by this, and that has no immediate means of recovery other than to get beyond this. And I would just say the one thing that is positive about our region is that, well, there are many things positive, but one in regard to this topic is the fact that there's been very high compliance with the appropriate behaviors of distancing, use of masks. And I think people have taken it seriously, and that's reflected in the low incidence rate we see now.
And Dr. Taubman, if you could address the topic of business models and what this crisis has highlighted.
I think that clearly the crisis has highlighted the vulnerability of the healthcare system in a way that we didn't see in 2008, probably could never have imagined. We saw pretty much of a 50% decrease in revenues across our entire healthcare system, which includes 6 hospitals and a pretty wide region. But most of our expenses are personnel. So you have that decrease in revenue, but you don't have the decrease in expenses that would go along with it. Plus, there are increased expenses related to PPE and purchasing ventilators in dealing with COVID. So just to put it in perspective, we're an academic medical center. We have a relatively small margin. It helps to support the university. We're 87% of the university's balance sheet. The university as a whole is the largest employer. That margin supports the university. It supports a very substantial research enterprise, which is actually one of the leading research enterprises for COVID. And within the first 2 weeks of the reduction, the last 2 weeks in March, the entire year's margin went to zero. And basically by the end of June, you're talking about roughly a $250 million loss, as opposed to what would be normally about an $80–90 million margin. So this is stunning. It required us to furlough 4,000 people. Fortunately, the good news is that the clinical enterprise has come back very quickly, much more quickly than we thought. So we're beginning to bring those people back. But I think, as Bill said, this is something that we're going to feel for a long time. We're not easily making up that margin. The support that we got from the various congressional acts still leaves a huge gap, and largely filled by a loan that has to be repaid. And I think added to this is that the university has lost a lot of revenue. They had to shorten their semester, give back room and board, give back some tuition. They lost revenue in the cafeterias, et cetera. And it's totally unclear what kind of class will be able to come back in September. It's a class that very much depends upon a substantial amount of foreign students. Unclear where that is going. So there's incredible uncertainty on the part of the university. So I think this really outlined the fragility of the clinical model. And I think it's making us rethink what we look like going forward. I think something that Bill said is very important. This is not returning to normal. This is redesigning. It's redesigning how we see patients. It's redesigning our efficiencies, because we saw how quickly, within weeks, how quickly this had an economic impact on the medical center and therefore on Rochester.
I would second Mark's thoughts on this point. This has been very humbling for an industry that has grown and become wealthier and more influential politically. But it's interesting, not just for healthcare, it's been so humbling across all of society because no one can elude the consequences. So it is going to prompt a lot of rethinking. It has to. And our vulnerability in the way we've structured our care, which has been largely to advantage the organizations that structure the care, is going to have to really be rethought.
So maybe connecting this part of the discussion with what we were mentioning earlier. So a second wave is likely, probable, maybe a matter of time. There's a pretty good chance that whatever rethinking and redesigning is happening is not completed by then. But all of your organizations have learned, and it sounds like from what a couple of you said earlier, that when the second wave comes, it may not require kind of the fuller scale or the fullest scale effort that the first effort did. So I guess the question is, so if and when that second wave, let's say, comes in the fall or early spring, how will your ramp up maybe look compared to the last time in terms of its financial impact on your organization? And if that's a existential or big event, I mean, what federal or other programs might need to be in place for your organization and for kind of healthcare in our region to be able to get past the second wave successfully? And maybe Townsend can start.
Thanks. Well, I would say, as Dr. Streck had noted, that this is causing Loretto and probably all healthcare organizations to realign their thinking around a new economic realities that are going to persist over time. We're anticipating the second wave coming in mid-October, late fall. And as part of that, we're preparing in a way that we didn't have the time and luxury to do previously. So for example, we're out in the market actively purchasing a 90-day safety stock of critical PPE. We are doubling down on our digitalization plans and making telemedicine the norm and not the exception. Likewise, we're actively looking for other technology tools that are going to assist us not only in remote patient monitoring, because half of the people we serve are community-based and in their homes, but in addition to that, better tools around contact tracing, around hot spotting, and just understanding the life of the disease, the virus. And so I think we will be better positioned when the second wave comes than we were the first time. But undoubtedly, the larger challenge will likely be that financial gap challenge to continue to meet the needs of our community, being the safety net provider.
And Dr. Streck, if you could address the same question.
Oh, we'll do better collectively, but there's no answer if we were really suffused with a repeat of New York City. It would just be another very, very difficult situation. But I think we'll all roll out better programs. As Mark pointed out, we have better clinical instincts and capabilities and protocols. But again, that we have to think it wouldn't be just us, it would be all, like for Mark or Kim, I mean, it'd be the colleges, it'd be the schools. I mean, the health system is so integral to all those components. We have 20 school-based clinics that really are important to some of the communities. If it comes back, we'll just, and it came back forcefully, which on an inpatient basis, it did not in Upstate. It will be a real, very difficult time. And the economic impact, as Kim points out, could be worse even than what has occurred thus far.
Dr. Taubman, when you and I actually spoke a couple days ago, I think you were thinking that from what's been learned that maybe it wouldn't be, for instance, as necessary, for instance, to shut down elective surgery. Can you talk a little bit about some of your thoughts about what a second wave may mean and how it might look different?
I would like to first say that I'm not sure that we should be talking about this necessarily in waves. I think we are seeing somewhat of a steady state. I mean, when I look at our peak, we were probably in Rochester, in Monroe County, not in the region, maybe seeing 100 new cases a day. We're seeing 40 to 50. The difference is that it's a different population getting sick, so we're not seeing the same number hospitalized, not same number in the unit. But I believe that, you know, we had a fair amount of social distancing. What Bill said is right. People were very good in upstate New York. We had time to prepare. This had to be imported into upstate, and we were looking for it. Now it's a little bit more indigenous, but I think we're going to see this 40 to 50 cases until there is a vaccine. And I think that what that wave will be is not because of something that comes back in October, but I think it's more likely, will we see a wave due to differences in social distancing? People are still being very good. What is frightening is that only 5% of the Rochester area population is positive. And maybe by December, it'll be 7 or 8%, but we still have a population that is incredibly vulnerable. 90+% have not seen this. So the ability to, if this got out of hand, if we went away from social distancing, particularly the good use of masks, which I think is our #1 issue, more than testing, it's the use of masks, it's keeping people away. We could see very, very quickly, way before October, a big spike. On the other hand, if we can keep people distanced, we may not see as big a spike. What I do think is that we have the PPE, we have the expertise. I think that we will get more leeway from the state. I think they see that we could ramp down our system within 4 or 5 days to have 400 or 500 beds available. We won't need that. Even if we ultimately need 400 or 500 beds, it's not going to be over a week. And I think they will therefore give us more discretion about what we do in terms of shutting down beds in the hospital, shutting down elective cases. I think they've also seen that one of the problems with shutting down all these elective cases is now we're seeing a lot of patients who may be sicker than they might have been because they were not getting care. What we have done is, and I think you've heard this from the others as well, we've redesigned the system to make people feel comfortable. I think patients feel very comfortable to coming in as an outpatient. They feel very comfortable about having procedures. So I think if we see a spike or we start to see that is significant, I think we won't have to respond the same way. I think if we really saw a breakdown in social distancing and a huge spike, then I think we're going to have to shut down the same way.
The only thing that's, well, one thing that's rising about as fast as COVID in some states is the number of states New York is quarantining. Yes. So, you know, that's the one source of a second wave that lurks out there for us. We don't really know if there could be, I'm not hypothesizing it, but if the rest of the country has higher rates, to think that that won't have impact. And then, as Mark says, combine that with a little lack of social distancing and masks, and we could recreate a scenario we have thus far avoided.
But that could be very quick. That's not necessarily October. That's people coming in now from states that are positive and the students coming back in August.
So one of the things that was notable in a couple of the answers earlier on today was the mention, for instance, of the acceleration of the use of telehealth. And so I wanted to ask you, kind of each of you, about that from your perspectives. To what extent has the increasing use of telehealth now and presumably kind of the further use of it, as well as some other technologies that perhaps hadn't necessarily been adopted as quickly, but now that we've kind of seen what we've seen from COVID-19, now that we're thinking about a potentially slightly different way to give care later, and just as importantly, perhaps even more importantly, finding cost-effective ways that they're still providing quality care to individuals. To what extent in your organizations do you plan for technology, telehealth, other monitoring technologies to be a key part of how you move forward? And maybe we can start with Dr. Townsend on that one.
Thanks. Well, it's been absolutely critical, and I think it will continue to be critical to Loretto having successful outcomes. So we're out in the marketplace looking for other technologies to add. So we've recently added screening technologies, kiosks, which will be located in all of our facilities, that will enable us to audit and track people coming in, and that will help us to early identify challenges. In addition to that, I would love to see an affordable CLIA waived point of contact COVID test, rapid test, become more available for health systems like Loretto. But I think that there are just so many technology tools that are being developed and just in the delivery of care within our system, connecting residents to their families when they can't be with their families. And we've done over 4,000 FaceTime visits between residents and their family members, but coming up with an affordable, ubiquitous way to connect individuals to their family members outside of our system. Those are all things that we have incorporated into what we do today, but are always looking for other technology solutions to some of our largest problems.
And Dr. Taubman, kind of what's the continuing role and future role you think of telehealth and other technologies in helping to care for individuals in the future?
Well, I think we learned a lot. I think that telehealth is something that we have been building on. We have a pretty large regional footprint, and it's a way of delivering medicine, particularly in areas where they can't have specialists, they don't have enough physicians. But I think given the circumstance, as I mentioned, we went from 20 cases a day to 6,000. But what we learned was that there are whole populations that benefited from that. We saw many fewer no-shows. There are certain groups that I think have embraced this and won't go back. Psychiatry, as an example of an area where they really actually saw they were seeing more patients than they ever did. There are a large group of patients in which traveling to Rochester is difficult, particularly if there are neurologic problems, infirmities, in which telehealth was far more beneficial. So I think it's here to stay. We're not at 6,000, but we're probably at 2,000. And if we have a reasonable reimbursement, that may not change. And will also be important because we can't see the same number of patients live because we still have to distance our offices, et cetera. You don't want people waiting in an office for an hour. So this, I think as long as we've got COVID, we're going to use it. But I think we're learning that this is a very important part of the healthcare system and is beneficial to allow us to see patients who can come and need to come and see patients who better off not. I think another thing that we did has been critical to our ability to protect our employees is we've used a chatbot to test all our employees every day. That's been incredibly successful in keeping our employees safe, our patients safe, and as part of that also enhancing our patient-reported outcomes, letting them use their phone and iPad to really provide a sort of blow by blow how they are doing symptomatically. I don't think those will go away. I think we're learning, we're going to employ technology again in a redesign because this helps the system. It helps us see more patients and it helps us to treat our patients better. There's a way to go. I think that monitoring devices are also going to come into the fore. I didn't play a big role yet. We didn't have major changes in how we monitored people. So I would say it was more telemedicine, chatbot, patient-reported outcomes, but I think that will come.
And I mentioned, Dr. Streck, at the beginning that your network covers about 5,600 square miles of territory. Thoughts on telehealth in the future?
Well, we like Mark and others, have been advancing telehealth and really had a good base. But I would say there were 3 lessons that COVID taught us about telehealth. First is when people are afraid, they will use it. And they did, so that our volumes of telehealth probably went up to 30 to 40% of clinic visits for a while. But another part of the social experiment is that now that things have settled, telehealth is back down to 10 to 15%. I mean, people, at least by their actions, indicate that they like to see their physicians or their providers or practitioners in person, despite the minor gauntlet of the COVID protocols to get in. So we're learning that there is still value in the personal interactions, and we learned that there is great efficacy in using telemedicine. The second thing we learned, all of us, is that if you get paid for it, it helps, and that helps move it along. And the third lesson that I would say from here that was really interesting is that because we needed to do it, it moved out of the arena of we do telehealth, like it's a division of telehealth does telehealth, and it traversed the whole organization so that all physicians and all practice sites and all specialties had to master telehealth. They had to learn how to get on with their patient, send them a link, whatever vehicle they use. There was a dispersion of expertise across a practitioner group of some 500 that was accepted. And had that been asked as a favor, we would be 2 years down the road, but driven by necessity, it's an established fact. So it's been a great social experiment in telehealth. And I agree, we're not quite sure where it will level out. It has some value and we will all pursue it. And then the remote at-home testing and all will build upon that.
So we want to turn to a couple of questions from our audience members. There's actually one that builds upon what we were just talking about. I think it's largely really, I think, aimed at Dr. Townsend and Dr. Streck, because you both have elements of what you do that are specifically serving the elderly population. And the question is really about the social isolation that a lot of seniors have had to kind of go through, and the impact for them and for other people who are medically compromised on kind of the mental health aspect of their lives. Could you talk a little bit about what you've seen and witnessed in your organizations, and what other ideas kind of are there for making sure that as we continue, in Dr. Taubman's words, that this is not about waves, this is kind of more of a long-term continuing issue. How can your organizations, how can we do a better job of not having seniors and others feel kind of isolated and having kind of the mental challenges that come with that? Maybe Dr. Townsend first.
Right. Well, as I said, we had to close our doors to visitors the first week of March, and we have not been approved as a sector of the healthcare system. We have not been approved to reopen at this time, and we had really anticipated that we would be able to reopen by the end of July, but I cannot overemphasize how incredibly challenging this has been for our residents and their families to not be together. over the last several months. And so those FaceTime visits, guaranteeing that we're doing those at least 3 to 4 times a week for each of the 10,000 people that we care for each year, has been a major thrust of our activities. We have done drive-by visits. We have ported people into their great-granddaughters' weddings. We have done so much to try to connect our residents to their families and friends, but it's just been incredibly challenging. What we continue to do with our families, and we have a family website, is just reassure them that the minute we get the okay to open, we will reopen. And it's going to look different. Visitation will look different than it did in the past. It's going to be highly managed. There'll be online scheduling, 30 minutes apiece, so that all families are accommodated, limited number of people, everybody will be wearing PPE. We'll have staff that will kind of help monitor and assist with all of this. But we are very, very eager to reconnect our residents with their families, much like the American College of Pediatricians, APA, saying that it was critical for children due to socialization to be able to do some in-person school this fall. I would say for a frail elder or an immune compromised individual, it is absolutely critical for their well-being that they be able to visit with their families in person as soon as possible. And we're just ready for that when we are approved to let that happen.
And Dr. Streck, I mentioned that your organization has part of its network some nursing home facilities as well. Could you address the same question?
Well, I couldn't give a better answer about the nursing home isolation than Kim did. I mean, that's really been an issue for everyone. And I would say, you know, for the population of patients, I would not claim we have expertise in seeking out those who might be in need of care. We did establish a mental health hotline, or to go with, along with the COVID hotline. We do have a home care program, but I could not say that we have a systematic approach to the isolation that has been induced by COVID. That would not be something as an organization I could claim that we are systematically approaching. I think the primary care practices that are dispersed, the schools, the school-based clinics, they can look at these elements and try to draw upon resources.
So another question, and we'll start with Dr. Taubman for this one. So a number of the answers here today relied on the idea that we need to kind of redesign and do some very significant things with the healthcare system with regard to things like funding and reimbursement. How realistic are the things that are being talked about in terms of what are the efforts afoot? How optimistic are you that these large scale changes can actually occur? And what are kind of one or two specific items that if you were to kind of take all other things aside, would you want to see our legislators, federal and state, be thinking about and working on?
You know, it's a tough one. Obviously, we need more, in general, more acute support. A lot of certainly the amount of support that we've had through the various acts still only covers a relatively small portion of this. And so I think acutely, you know, we're hoping that there'll be more iterations of CARES Act, and that some of the support, which is loans that have to be paid back quickly, are either deferred to a much longer payback. For us, we're talking about hundreds of millions of dollars. The difference between paying it back in December and paying it back over 5 years. Low interest rates as opposed to high interest rates. So these are some of the short term. I think in the longer term, I think we have to look at things like the reimbursement for telemedicine, the reimbursements for using technology, and I think people will have a better understanding right now than they've ever had before of how fragile the healthcare system is. I mean, I think there's been this sense that there's a lot of money in the healthcare systems, and you can pull it out. And I think what people have learned is that's not true. That a lot of the money is going to support a large number of, it's most, for us, it's about 70% people who, we're the largest employer. It's important. There's not as much fat in the system as people thought. So it's going to have to make people start rethinking, how do you create a reimbursement system that allows the system, that allows the healthcare systems to survive? That it can't simply be, let's keep providing less and less money and see how far we can go. I think that on the other side of it, we're learning how to be a little bit more frugal. I think, there's large populations that we sent home who can work at home. And maybe going forward, we'll want them to continue to work at home. And that will cut expenses. But what I would like to see is people take a much broader view on in understanding what the real expenses are for the healthcare system, how fragile it is, and then to think about what goes on with Medicare, Medicaid, commercial reimbursement in a way that allows our systems to survive. And I don't think that people really thought about the sustainability of large healthcare systems until this crisis. I'm not sure that fully answers the question, but
well, maybe as well as anybody could, I suppose.
That's what I'm hoping.
It's a hard question, but I'll persist nevertheless on to Dr. Townsend. So it's really same question. I mean, what are the one or two kind of systemic key challenges, and do you think they're realistic in terms of accomplishing them in the coming year or two?
Well, as a safety net provider, as I said, 63% of the people we serve across our system are Medicaid eligible. Medicaid in the long-term care setting has not had a cost of living increase, a trend factor increase in 12 years. In fact, we've sustained a 1.5% cut since January of this year. And so I think getting to a sustainable rate where safety net providers will be in a position to pay staff appropriately, get the PPE that's needed, and continue to proliferate the use of technologies, which are not inexpensive, are critical. I think in the short run, what we need to see from the federal government is support of state and local governments, because New York State is not in a position to provide relief to any healthcare provider because of its own budget gaps. And so we need the federal government to act quickly to better support state and local governments. In addition to that, it would be extremely helpful if we had a national strategy, broadly speaking, in terms of how to manage this. Testing, a national testing plan, a real true national stockpile of PPE to assist state and local governments. So there's a lot of opportunities for the federal government to step in and to be helpful particularly as we face a second wave, or perhaps, as Dr. Taubman indicates, just a persistent first wave.
Mark and Kim have summarized it. I would have nothing really to add to those observations other than short term, we need money from the government. That's one translation. Mm-hmm. Long term, if we're talking about a digital transformation, I think, Mark, all of us, colleges, are going to be looking at buildings. I mean, how much structure does it take to deliver care in a realigned system, particularly a digitally driven one? I think that in the longer term will be one of the questions for us to grapple with.
Excellent. Well, thank you all very much. We are at 12:58, and I will turn it back over to Nasser for a few final words. But thank you to all the panelists for joining us today for this important conversation.
Thank you again to all of our panelists. I know how busy all of you are, but this is an incredibly important topic for us all, and we appreciate your coming together to share your perspectives and give us some guidance in terms of how to think about the future. This is the next series in this Rebuild Upstate piece will be on higher education, which is another area, as you can imagine, of our economy that is being hugely impacted. I wanted to say a few thank yous to our media partners, the Central New York Business Journal and the Utica Observer Dispatch. The Rochester Beacon, of course, has been wonderful to work with. And if I can make a plug for our moderator, Alex, he's also a serial healthcare entrepreneur with success in iCardiac behind him. And the next one on the horizon is Clariovision, which is another incredible upstate company. We were able to chronicle some of his story in the Upstate Founders Playbook that came out last year. You can find it on our website. And for all of our attendees, thank you for joining us. And if you find these to be of value, please consider making a donation to support UVC at uvc.org/donate. Thank you all again.